Thank you very much for inviting me to come to this place. Usually whenever I speak, I try to give a disclaimer that I'm from the northern parts of South Africa. It's a place called Venda. So when I speak, I may be speaking with a bit of a Venda accent. So if you can't understand what I'm saying well, just raise your hand and I will repeat in the same Venda accent. What I thought I was going to do was to just touch on a number of topics. I will try not to go too much into detail, and in fact I had to wake up this morning and try to cull off a lot of slides so that I don't kind of make them too much data heavy, because what I'm trying to share with you is more the experience and how that experience of implementing pneumococcal vaccination was introduced in the South African experience. So I will talk about the structure that kind of drove this process, and I'll also look at a few things that the structure looked at to be able to achieve this, and then maybe we can slightly discuss and reflect on specific issues that were quite important in the South African experience. My life is actually made simple by the fact that there's been a lot of work on pneumococcal disease that has been published over the last 2 decades from South Africa. In particular, as far as the implementation of this is concerned, there's a very good paper that colleagues from the National Institute of Communicable Disease did to reflect on the process itself. You can see the top paper here by Shabir Mahdi, into how research was translated into a solid policy framework. And this paper here, which was published a few years ago in the New England Journal of Medicine, shows the surveillance platform before and after the implementation of that. That gives you a reflective space in which to kind of see how the implemented policy actually is working and how to evaluate that going forward. So just a bit on the South African NITEC, because I think this was key, and this will come through as we're talking about this. By definition, the NITEC as envisaged, I don't know if any of you have looked into a WHO page. There's a very good WHO on what they call the NITEC Support Center, which is based in WHO HQ in Geneva. The South African NITEC came into this space in 1993. If some of you may have some idea about the South African history, South Africa, prior to 1994, was an apartheid state that had different so-called independent homelands. So it had a lot of health systems within the same country. And when the new democratic government was formed in 1994, it had put all this together into one central Ministry of Health. As part of that process of restructuring the healthcare system, the Ministry of Health decided to have a NITEC. It became known as the National Advisory Group on Immunization, or NAGI. And it has evolved over the years, but followed the template that is now universally adopted through WHO, which means this group had to be independent. By that, it means it's chaired by an independent person who is not part of the formal bureaucratic structure of the Ministry of Health. It's then composed of experts that are, again, independent. They don't serve specific constituencies. They only are there as experts in their field. And it involves people from pediatrics, public health, microbiology, people with experience in epidemiology and clinical trials, and other people are brought in an ad hoc basis, but with the core members involved in that. But what is important is that the Ministry of Health is also represented through a representative of the Director General, and in our case, that is the Directorate for Maternal and Child Health, in which the EPI is actually housed. That way, although they are not core members in that they don't vote or they are sitting there, which means immediately the ministry knows what the deliberations are, and the ministry also, because it's represented, so there is not a middleman to kind of speak to the ministry because the ministry is represented in that body. And that's basically what actually facilitates any advice that is given to the Ministry of Health. The issue came up earlier on about what happens with advisory groups. So right now, as I'm speaking, the South African NITEG is trying to review policies in terms of our pertussis vaccination, for example, and vaccination of HIV-infected adults and adolescents and so forth. What usually happens is that a working group is created from the NITEG itself. That working group can find members who are outside the NITEG, but it's still going to be chaired by a NITEG member because that person is directly connected with the function of the NITEG. Again, the working group is independent. Of course, the Ministry of Health funds the logistics of running this, of bringing members together, of transport and so forth. But that is basically the structure that that actually works with the NITEG. So the NITEG was quite key in that. It does not have any kind of powers to implement policy. Its role is advisory, but that advice is independent of the Ministry of Health. The ministry can reject the advice or it can accept it. And if it does reject that advice, it will have to give reasons as to why the advice is not acceptable. But that's part of what that process of independence actually involves. Each member is appointed by the minister to give independent advice to the ministry. I don't know if that makes sense. And the grounds for making advice have to be justifiable, have to be scientific, and so forth. Quite often, you may ask what then is discussed. Who decides what topics to be discussed? Quite often, because it's a group of experts, they are working in the field, in pediatrics, in microbiology, and so forth. Key issues do come up from the members themselves, and they bring that in. But in the same time, lobby groups that come from, for example, the issue that we just recently finished, which was of birth dose for hepatitis B, which was not part of, and is still not yet part of the South African EPI, was brought through by hepatologists and gastroenterologists who were worrying about issues like hepatocellular carcinoma, and they felt that this needed to be incorporated into the program. They brought that to the Ministry of Health. The ministry gave it to the NITEG and said, please discuss this issue and give us advice. Recently, there were outbreaks of case of diphtheria in one of our provinces. In 2 provinces, this has happened. And the ministry came to the NITEG and said, look, we're worrying about issues like this. Should we not be giving another diphtheria dose later in life? Do you mind discussing this and see if you can advise us on what to do? But in the same time, the NITEG would say, actually, why not combine this with the booster dose for pertussis later in life? Instead of TED, make it TDEP, because we're worrying about the outbreak and resurgence of pertussis. But that is basically how issues are brought in. But once they've been deliberated in an organized scientific way, where there's a working group established to deal with those issues, chaired by NITEG members, then the advice goes formally to the ministry for final endorsement and translation into policy. That is basically how this works. I hope that answers part of that question. Okay. So, as far as the pneumococcal vaccine was concerned, a number of issues had to be key in terms of making this decision. And part of it was to have very good indication from the NAGI members about the epidemiology of pertussis in the country, to that the intervention, in this case was pneumococcal vaccine, was in fact effective. And then the last 3 things basically spoke about the feasibility that had to involve cost and affordability, and cost effectiveness and affordability. And I'm deliberately separating those 2 things because they are not always the same, and we'll talk about it maybe a bit. And then what the impact would be in the country, and then ways of evaluating that going forward. So I think Susan will probably talk about this later as you do the workshop later. There are many ways of collecting data in South Africa. Part of it include national statistics of disease, conditions, and death, and mortality, and so forth. But there is specific surveillance programs. This group called GEMS is actually it's a group that surveillance is enteric, respiratory, meningeal surveillance in South Africa. So it's a group for doing so. That's why it's nicely called GEMS, right? And it's got a number of sentinel sites, in which case high quality data can be collated. This is a map of South Africa. So we've got 9 provinces, and there are a number of these sites that then feed into the NICD, which is housed in Gauteng mainly, to try pool national data, and trends are then quite clearly established. But over and above that, the National Laboratory Services do collect data that comes from normal clinical specimens sent into that are sent by different hospitals and services into that space that are not part of the Sentinel sites. And that gives a broader perspective and picture, because our laboratory service is now centralized, which means wherever you take specimens in the country, historically, each area would have its own laboratory, and there was no pulling of data together. But now there's one single national laboratory service. Although there are different laboratories all over the country, they feed into the same system. So whether I'm in Cape Town or whether I'm in Pretoria, I can immediately see data that is collected elsewhere, or any of my patient who moves around, I can track them throughout the whole country. And that's all goes into this national surveillance program to be able to establish patterns of disease. So when it came to this, I mean, again, I'm going to try to really avoid most of the nitty-gritties of the data, but just to highlight the important things that were important. These are the trends that we're seeing over the last couple of years, and I hope that, and thanks to Susan, I got these slides from her, so as she's part of the groups that has been doing this. I think what's so important for me is to see before PCV7 was introduced in 2009. This was the epidemiology of disease, of invasive pneumococcal disease in children that was reported. Again, you'll notice which serotypes, the age groups in which those were happening, and you can see that the invasive pneumococcal disease was mainly in the youngest group of children. And then this slide just shows the serotypes, that is PCV7 and then PCV13 if you add that to that, and then these are non-PCV serotypes that were represented in that epidemiology. This may look, interestingly, much lower than maybe data from other parts of the world. Like this is data from America. I'm just showing that for comparison. Now, this is quite important, and I think Susan will probably allude to this, that there's always been a feeling that whatever you look at, you actually underestimate in certain geographic areas. So, for example, not everyone does blood cultures in our country, so there's not standardization in terms of practice, even if in policy, there's standard policy in terms of how you should approach the investigation of sick children. A number of rural areas don't, for example, send blood culture samples, which case you underestimate part of that. Over and above that, when it comes, remember that invasive pneumococcal disease includes meningitis as well. Quite part of our policy in childhood management includes the IMCI, which means, and ceftriaxone is our standard state dose. Over the last couple of years, and from clinical practice, we have noted this, that even though you make a diagnosis of meningitis, you cannot tell what organism it is, because by the time children leave the primary health centers and get to hospital, where either blood cultures and lumbar puncture sampling will be done, they may have already received an antibiotic 5 to 10 hours earlier before they arrive there, which for us, that's why even in some of the conditions like meningitis, people are talking more and more about using to a PCR-based diagnostic platform, because we are just not culturing these organisms because of the management. We believe it's saving lives, and that there's early intervention, but it's got implications in terms of our surveillance and knowing what's going on. Okay, so am I going back or forward? So here I'm just showing again the same data. Again, I'm going to go pretty quickly because I think I've already taken a bit of time. I've really taken a bit of time. Okay, I think Susan will talk about this, but this is just showing again what the serotypes, the number of the serotypes that were shown. But this is an important slide, and I just want to show this to you because this was important. You don't have the same problem as we have in South Africa and Sub-Saharan Africa. It's a problem of HIV. So although these patterns look similar, in under the 2 years of age, you'll notice that this is in hundreds, whereas this is in tens. So the burden of invasive pneumococcal disease in the HIV-infected cohort was huge. In fact, invasive pneumococcal disease in HIV cohort were responsible for about 2/3 of all reported cases in this age group. And still, while they were less than 10% of the whole population. So you can imagine what that was so important, because it was going to be key in terms of whatever policies we came up with. So it was huge. And at the same time, they had about double the case fatality rate with invasive pneumococcal disease. So this was important. And they also had about 10 times the admission hospitalization rate when they get sick. And we'll talk about other issues that are also important, because it also comes up here. If you notice, it was also, the surveillance showed that the HIV-infected children had much higher level of penicillin resistance. And the good part to look at was that to realize that those strains that are represented in the vaccine actually had much higher rates of penicillin resistance and also cotramoxazole. So these were important. So the issue with us in South Africa was not just the heavy burden of pneumococcal disease. It was that there were some populations that were specifically higher at risk, and they also contributed higher to both mortality, morbidity, hospitalization, as well as proportion of antibiotic resistance. You can imagine if kids are coming repeatedly with otitis media and other infections, you kind of start selecting out resistant strains, and that's basically what started happening with HIV. So what was then noted, you can look here on the side, is that when you look at these serotypes that were contained, that the estimate then was that about 70% were covered with PCV7, about 25 if you go to 10, but goes to 85% when you go to PCV13. But the second part that I needed to do was to show the effectiveness of this, and I'll go pretty quickly. I'm sorry, just to stop. I'm quite happy to give references, and you can email it out from most of the basis of this analysis and assessment. So it became quite clear, studies both international and specifically in South Africa, from around 1998, there were a number of studies using pneumococcal vaccine, PCV9 at that stage. It basically means your PCV7 plus 1 and 5 strain, and not the 7F. It was not included in that, which is in 10. Showed clear serotype-specific immune responses. They were positive, and they were quite good in both HIV-infected and HIV-uninfected children. But it also became quite clear that any schedule that only gave the primary dosing did not last long enough into the second and third year of life, especially so in HIV-infected children. So they had lower immunity, still responsive, and so that was important, that there was such a decline. Secondly, there was quite clear evidence that carriage of strains due to the vaccine serotypes were reduced when they were vaccinated, and in particular that targeted those antibiotic-resistant strains which were affected in terms of reduction in carriage. And then there was this kind of herd effect that started protecting other groups, including the elderly, that were not vaccinated. As far as invasive pneumococcal disease, which is basically the hallmark for surveillance, is that the vaccine efficacy seems to be 83% in HIV uninfected and about 65%. However, although the vaccine efficacy was lower in HIV infected, the vaccine impact was much greater because they had the largest burden of disease. In fact, it was up to about, I think almost about 20 times more in terms of the reduction in those cases. It was huge. The reduction was huge in this group. So lower vaccine efficacy, but in a group that contributed the largest burden of disease. And then there was this issue about all-cause pneumonia, which was important. Again, pneumonia is a nightmare to diagnose for research purposes. Everyone knows that. But it started showing that in the children that were HIV uninfected, although the vaccine efficacy was 20% and 13% in HIV infected, again, the impact was much greater in the HIV infected population because they contributed most of the pneumonia in these age groups. So these were the bases that started showing that this was actually working. So prior to 2009, this basically was the South African vaccination schedule. It contained virtually 7 vaccines against 7 diseases, like most people do. The last one that had been put in was hepatitis B in 1995. Prior to that, Haemophilus influenza B, I think it must have been around 89 or so. And so now with the decision to incorporate this, there was kind of going to be major impact in what will need to happen to that schedule that we actually had and what the impact of that. So the decision, apart from looking at the issue of cost and other things, needed to look at that. This is just a cost slide. That basically what was at that stage. All those that we were using, those 7 vaccines, were about $11 to vaccinate a child. By adding, oh man, what happened to my, it's just flashing. The adding pneumococcal vaccine, I think that's because I made it on the map. Adding pneumococcal vaccine was added another $75 to that schedule. So the schedule went basically 7 times higher by adding the conjugate pneumococcal vaccine to that schedule. So that was huge. It was an important decision that needed to be made. And that was considered, but in the South African context, the colleagues in London, David Goldblatt and others, had just shown that if you give 2 doses of vaccine, and you put a gap between the first and the second vaccine of not the regular, remember that when you give, the studies have shown that if you give the response to immunological response after the second dose was much higher than after the first dose. And the increase after the third primary dose was not significant compared to the second dose. But moreover, if you give 2 doses, but instead of separating them by a month, you separate them by up to 8 weeks, the immunological responses were much higher. South Africa considered that. And because there was an issue that I noted earlier, that the immunity started waning and not protecting the second year of life, it was not possible for us to just stick with a primary schedule. So it was not an option. We needed to protect children, especially HIV-infected ones, going into the second year of life. So we needed a booster schedule. As a result of that, what we then decided was to put a booster dose at 9 months. And the reason for that was because our own EPI review showed that our vaccine coverage became poorer as you went into the second year of life. So we still had reasonably good vaccine coverage at 9 months of age. So pushing it later would have been much harder. And in the same time, at that time we had measles at 9 months, so it was going to coincide with a measles vaccine schedule. I can try to explain to you why we've got 6 and 12 months now. It's a long story, and it was only informed by logistics and lack of availability of vaccines. But at the same time, the issue you raised about multiple doses were coming into the picture, including the polio endgame, where we knew we would have to translate into an IP-based vaccine. So what happened at the same time as the pneumococcal vaccine was introduced, we changed from whole cell pertussis in a DTP regimen, and we went for a pentavalent vaccine so that we put all the doses together. It became cheaper, logistical as well, that you had only 1 dose. In fact, now, since 2016, we've moved to the hexavalent dose because it put all the vaccines together, which is why at 10 weeks, you basically have got only 1 shot of vaccine. That's only 1 injection. And all those things were considered into the schedule, but they were very specific and particular to our own review of our vaccination schedule, about our vaccine coverage, and the cost. But it basically meant, as far as the cost is concerned, that although there was clear indication, and I'm not giving the numbers here, that that vaccinating against with pneumococcal vaccine is a cost-effective measure, the issue of affordability remained a problem. So, and the reason why I'm separating these two is that we can know what is cost-effective. But remember, the problem with vaccination is that the benefits are in the future. You may not have the cash investment now, even though you know over the next 5 to 10 years' time, you'll save money. And that's basically where South Africa found itself. And the only way of doing that was showing that by taking 25% of the cost, it brought the vaccination schedule into affordability. Because by going to a 2+1 schedule, we took out 25% of the cost by having 3 as opposed to 4 doses. And the government agreed that that will be affordable. Cost effectiveness was not an issue at all, but it was affordability by government in terms of the money that they had in the kitty. And interestingly, this has actually revolutionized schedules all over the world, because WHO then has adopted the 2+1 model from the South African experience into a vaccination program. So, where to in the future? I'm about to finish now. It's the issue about using pneumococcal vaccine in special populations. I was part of a group that actually put the guidelines for the HIV Clinician Society. I think Susan was part of that group too, where we know that the benefits for conjugate pneumococcal vaccine are huge for HIV-infected adults and adolescents. And the working group has been established now, for example, in NITEC, to start deliberating those issues. What should we be doing in terms of that? What about change in schedule? These things are coming up now. I'm sure some of you are aware of what's happening with JCVI in the UK. They're actually now looking at the possibility of going to a 1+1 schedule as opposed to a 2+1 schedule. And that's something that countries such as ours that are low and middle income country but not Gavi supported will have to think about this, whether that schedule can be effective in those circumstances. But you're going to need to understand the epidemiology of disease in those areas. You're going to have to decide whether you need to start with more doses, and then once you've had requisite coverage, bring it down to a lower schedule. But this is something that rich countries, including the UK, are now considering as a way of going forward to 1+1 schedule. And this is going to come in the South African discussion soon in terms of whether this should be the way forward in terms of considering that. What about new vaccines? There are stereotypes that are not covered. People are talking about PCV18, PCV23 in terms of conjugate vaccines going into the future. And then the issue of continuing surveillance, which we showed was important. As you can see with the previous slides, the intervention with PCV7 and 13 had an impact, but we can actually measure that and feed back to policymakers that their investment has actually been quite successful and it has been fruitful. So in conclusion, PCV has had a huge impact on the burden of pneumococcal disease in South Africa. But we have learned that local epidemiology needs to inform this intervention, both in knowing that you need to intervene and also keeping tabs and surveillance on how that intervention is actually working. But that it's also important that the vaccine choice and schedule must adapt in response to both new development and knowledge, and in particular, if the issue of cost has to be dealt with, we probably need creativity and probably a bit of bravery in terms of translating what is known into a practical vaccine schedule that is both cost-effective, affordable, and sustainable in the long run. Thank you very much. I just want to thank again Susan for giving me some of a surveillance slide as a member of the NICD and GEMS group. Okay, the first one is one of your slides, or two of your slides, showed that there was an increase in non-PCV serotypes. The question is, were those non-PCV serotypes pathogenic? Did they cause any of the IPD? You want all the questions, or you want to answer one by one? I think to be clear, and Zen can help with respect to this, that what I was showing you now is actually invasive pneumococcal disease. So these were isolated from clinical patients. So they were there because they had caused disease.
Okay.
But what you'll notice is that although that's happening, they are happening at a much lower frequency than where the epidemiology of all pneumococcal disease used to be previously. So you'll notice that it was looking at less than 1.8 per 100,000 when we have moved from 80 per 100,000 initially before the introduction of pneumococcal vaccine. I don't know if that makes sense. And that, in many ways, was expected because the trends in countries that had initiated PCV earlier had shown that there will be strain replacement as a result of that.
Yeah. Okay. Yeah, I've heard that before.
Yeah.
The other question is, you heard about you mentioned about herd effect, but none of your slides showed that. I mean, was there a decrease in the more than 65-year-olds who were not vaccinated?
No. So there are two things here. There are two groups of data. One is the use of local South African surveillance data as well as research data. And secondly was amalgamating data that was also found elsewhere in the world into understanding what the impact of the vaccine would be. So for example, what was noted is that all-cause pneumonia seems to have reduced. And the previous data had shown that the majority of invasive pneumococcal disease in pneumonia was due to strep pneumonia. So it was an indirect inference than that was actually the case. I don't know if that makes sense. So the inference was that the vaccination in this group has reduced all-cause pneumonia overall in the national surveillance of prevalence of disease.
Right.
So we actually did observe herd immunity in other age groups. In South Africa, we have two peaks of invasive pneumococcal disease. One is in our less than 5-year age group, focusing on the less than 1-year-olds, and the other is actually our 25 to 44-year age group. And that is due to the HIV epidemic in our country. So adults are getting a lot of pneumococcal disease, and we saw a 40% decrease in that age group. We actually didn't see a decrease in our over 65-year population because we actually have a very small population group. Our life expectancy has only just got to 60 years in South Africa. So that group we didn't see as a great reduction as they saw in the US. But the 25 to 44-year age group, during the time that we introduced the vaccine, we also had a massive rollout of antiretroviral therapy. So the HIV epidemic was now being controlled a little bit, so they were giving people antiretrovirals to just help stop that suppression of the immune system. So what we did when we actually analyzed this data is that we looked at the vaccine types in the 25 to 44-year age group as well as the non-vaccine types. And the vaccine types decreased by about 60% in that group, and the non-vaccine types decreased by about 20%, and that's probably the 20% decrease was due to the ARV introduction, but there definitely was an indirect effect from the vaccines.
Thank you. You don't seem to have a problem with 19A. I mean, it's a famous serotype, so everybody wants to ask about 19A, and you don't seem to have it. I mean, we don't have that much of a problem, I think, with 19A. I think it looks from your slides.
We have quite a lot of serotype 19A. I think one of your slides will have shown the serotypes in the vaccine. So serotype 19A has been a problem. It was always a problem before the introduction of PCV7. So unlike the US and the UK, they tend to blame the introduction of PCV7 with the increase of 19A. We already had a high number of 19A and serotype 1 circulating in our country, and that has gone down tremendously since the introduction of the vaccine, the PCV13.
Okay, thank you very much. Last question, but this one you can answer.
You sure this is not surveillance?
This one is about multiple injections per visit. what's the cultural take in South Africa with regard to parents who are they acceptable to getting multiple injections per visit, or would they rather have one injection as a whole?
We really haven't had much of a problem with respect to that. The issue that we have is multiple visits. That has become an issue. As I showed you before, we preempted that when we added pneumococcal vaccine by combining what used to be 3 injections before into one, and now when the 4th one came, now we've got 4 injections have now become 1. That has reduced the number of injections pretty, by 75%, in fact. The issue that we have is that because of loss of a supplier for the measles vaccine that we used to use at 9 months, we're forced to move to a different vaccine that cannot be given according to our medical licensing board at the same time as another vaccine. So we had to create a new schedule at 6 months and 12 months to fit in. And that we still haven't, the surveillance data for vaccination has not shown a huge negative impact in terms of parents not bringing their children. So I think we're doing reasonably well. Partly it may be because a large proportion of our population are people from rural areas that will accept the intervention by the medical care fraternity. We are seeing changes in urban areas and more affluent areas where there's probably more resistance and also emergence of what one would call the anti-vaccine lobby.
Right. Yeah. Okay, you don't have to answer the next question, but it's just to tickle the Ministry of Health. Would you recommend that the Ministry of Health move from the pentavalent to the hexavalent vaccine, cost aside?
Well, you will have 1 less injection, and if you multiply that by the number of doses, it probably will have an impact. I don't know. For us, the logistics meant that, remember, every vaccine has to have its own logistical capacity. And usually when you think about it, people tend to only look at the cost of the dose. So what you need to look at is what the cost of the dose is, plus what the cost of the logistics of maintaining that vaccine in a usable state and so forth. And then the next thing is the societal issues. I think the hexavalent, people find it quite expensive. And it may be the single most expensive thing when you look at it in combination. But if you break the vaccines, it becomes cheaper because you're paying for 6 vaccines. But that's just something to think about in terms of logistics. Thanks.
Okay, Dr. Aisha.
Dr. Rudzani, talking about the NITAC composition in South Africa, you mentioned it has to be basically scientific and independent, but you did mention there is a composition of political representative from the minister. So how does that becoming?
It's less political. It's actually, remember, if you think, I know this is difficult for both Malaysia and South Africa to think of it this way. When you see a Director General of Health, you usually think it as political representation, right? But it's actually supposed to be representing the bureaucracy, which should be independent of the politics. The politics should only give policy, but translation of that policy is actually a bureaucratic function. Usually for most of our countries, it's very difficult to separate those two things. But they are there to be able to take that recommendation and translate it into policy, which is the job of bureaucrats, given the overarching policy framework of the politicians. So it is, one, they don't chair the meeting. They can't determine what the agenda looks like. They can contribute to the agenda, but without them there, you end up with a middleman scenario where they are not there when decisions are made. Yeah.
Okay. Second question is your high prevalence of HIV infected in South Africa. Is that the reason why you have successful reduction in in pneumococcal IPD. Can you actually separate? I mean, what's the effect in the non-infected children? Because when I think for us, we have actually introduced this PCV among the high-risk population, even though it's for HIV-infected children is not a major problem in Malaysia.
No, actually no. The surveillance data showed that the impact on the HIV population may have been greater, but the introduction of the vaccine, as you saw that, my slides are gone. If you see those slides, and I think Suzanne will probably show this later, I've separated the two groups, HIV infected and HIV uninfected, right? There is a clear indication of impact of the vaccine in HIV uninfected individuals. There's another slide. Let me just move to this. If you look at that, the top part, that is HIV uninfected children, whereas this HIV infected. I just wanted to show that the impact on the HIV infected was huge. Again, as Susan pointed out, this came in the same time from 2004 to 2005. There was a better rollout of antiretroviral therapy, and the PMTCT started bearing fruit. So the children who were born with HIV has greatly declined to less than 1% over that time period from HIV-infected mothers. So that is not the case. And we also know that if you look worldwide, in the US, in the UK, the impact had nothing to do with HIV because they didn't have the same burden of HIV. So we knew it worked. What we just needed to know was whether it also works as well in HIV-infected individuals, and the impact was actually much greater.
Thank you very much for the talk. I did brought this up during one of the meeting with the people involved with PCV. You have not shown us anything about mortality below 5 years. You are showing mortality below 5 years. This is what Malaysia usually look at. But I did mention to the group that I think if you were to just look at below 5 years mortality, you will not find that many for IPD. So should we look more for the less than 2 rather than less than 5?
Our data is actually used, the ones that we basically based most of this decision on was the below 2 years of age, because that's the highest mortality. Mainly part of it is that a lot of mortality is due to pneumonia type disease, and that high burden there is the same thing with when we look at pertussis and other respiratory infections. It tends to be in that age group. For us, I think the mortality was still high prior to 2005 because of HIV, but the introduction of a good antiretroviral program has changed that pattern. But the mortality that determined for us that this was important to do was that under 2 mortality. I think what would be useful would be to desegregate that into different age categories. And if you want to look at, because again, when you're giving the pneumococcal vaccine in your first 2 years of, the major group that you're targeting is the group that is likely to die, and that group is those less than 2 years of age. I would not ignore the less than 5, but I think desegregating it into those different groups I'll give you a much better picture of what's going on.
That is just the cost of the vaccine, or South Africa has included all the other parameters?
If you look at that, we actually, I put there that it excluded the delivery and the logistics of it. This is basically the cost of the dose, as it were. But as I was saying, that is why part of that, when we made the decision, we started realizing that by combining 1, 2, and 3 into one logistical thing, you also cut the delivery costs and the logistical costs. So that is, I'm just talking about the cost of the vaccine. But these things are much more complicated in the sense that quite often, you probably should not look at the raw market cost of a vaccine, because when tenders are made to government, number of concessions are made in terms of subsidies and stuff like that, partly because they know that they're guaranteed a very large population of recipients for the next couple of years. And that is when you leave it to your politicians to be able to negotiate a good deal, given that there will be, I don't know how many children are born in Malaysia. What you're offering them is to say, we will be purchasing so many doses from you for the next 5 years or whatever else it is. And so the market cost should not be necessarily, it's not necessarily the real cost, because a different cost should be considered when it comes to that.
Okay, I was told by the Secretariat. Okay, one final question. I mean, I'm just wondering whether, Dr. Rudzani, I mean, can you share our insight with your NITEC before you decide on choosing PCV 13, 10 or 7, whatever? I mean, what is the metrics in the decision-making process before you decide on that final? Although the other vaccine may be a discount, why did you choose the most expensive? I mean, is there any reason to that?
I don't know. I think you will have to talk to the manufacturers. but for us, when we started, there was only PCV7 in the market. So that was just basically the NAGI advice was to start giving pneumococcal vaccine because that was what was available. And I think when PCV13 came into the scene, the difference in benefits and what the government could negotiate in the tender space meant that they went to PCV13. I'm not sure about the real logistics of how they decided on one. Usually when it comes to this, NAGI would not have said go for PCV10 or 13 or whatever else it is. They said we need a pneumococcal vaccine and the difference in coverage is going to be this and that, and then government would probably have decided that it was more cost effective to going for one as opposed to another. But at the time when PCV7 was introduced, it was basically what was there in the market.
Shall we actually thank him in our usual manner? He needs to be on his way to Bangkok, yeah?